I'm Ben Ryman, and this is Behaviour Speak. This conversation delves into the complexities of aging, cognitive decline, and the role of behavior analysts in gerontology. Nehal Siam and Jacqueline Pachis discuss the importance of adapting care to the evolving needs of older adults, the significance of quality of life assessments, and the impact of cultural responsiveness. They also explore the challenges posed by ageism, the necessity of using appropriate assessment tools, and barriers to utilizing assisted devices. This discussion emphasizes the need for ongoing education, networking, and advocacy within the field of behavioral gerontology. All right, welcome everyone.
Thanks for having us.
Yeah, excited. Before we get started, I just want to acknowledge I am producing this podcast on the territories of the Klamath, Clayhus, Homoko, Comox, and Sechelt First Nations. I'm grateful to be here. So, welcome back, Nehal, and welcome for the first time, Jacqueline.
Hello.
Nehal, we'll get start with you again. Tell me a little bit about yourself.
Sure. So I'm Nehal. I'm a board-certified behavior analyst and a registered behavior analyst in Ontario. Been in the field for about 9 years now. Recently kind of shifted over to full-time teaching at the post-secondary level. But I've kind of worked with many populations over the last 9 years. I started off in autism and developmental disabilities, children and adults. And then I made the shift to older adults, working with the geriatric population. And even then across multiple settings, initially supporting long-term care homes. And then the last couple of years, I was working more on an inpatient unit at a psychiatric hospital. So majority of the patients I've worked with had some sort of neurocognitive disorder, but we also worked with individuals who had other underlying psychiatric illnesses as well. So that's sort of what I do. And yeah, the majority of my work has been really behavioral consultation, mediator training, so I kind of somewhere along those lines.
Yeah, right on. And Nehal was my guest in episode 228, and you can get a in-depth look at a good chunk of Nehal's life and story there. And so I refer folks there. So Jacqueline, how about you? Tell me about yourself.
Yeah, I'm also a board-certified behavior analyst from Ontario. I did my master's degree in ABA at Brock University. Been working in the field for 10 years, starting off with autism spectrum disorder, working in ABA. I'm also at the tail end of completing my PhD in clinical psychology with a focus on gerontology. And just broadly, my interest is working with individuals across the lifespan who kind of present with complex health and mental health presentations. And I have a particular interest in older adults and how do we use behavior analysis and clinical psychology to support older adults and maintain quality of life as they get older.
Yeah. I'm going to ask you a few questions that Nehal answered in the last episode. So how did you first kind of get into behavior analysis?
Yeah. So, I mean, like many behavior analysts, I started out working in ABA with children on the spectrum and their families. I think even like before that, I was always interested in working with individuals who had special needs. Like way back when, worked as a camp counselor, I'd always kind of worked with that population. I earned my master's degree in ABA. I really enjoyed that work and continued to work in that field and with that population for several years before I went back to school and got my PhD. But I think what truly kind of pulled me into behavioral gerontology and working with older adults was my thesis research at the time. So for that project, I got to explore how we could use prompting procedures to teach older adults to use technologies and internet skills. And that was just kind of a really cool moment for me because it was just a whole new application of behavior analysis that I just wasn't exposed to before. And being able to see how behavior analytic technologies could be translated to a different population. And so after that experience, I knew I wanted to just keep building on that knowledge and learn more about diverse applications of behavior analysis. And so I continued to work in the field for a few years, became board certified, and then eventually pursued my PhD in clinical psychology just to dive deeper into gerontology and apply my behavior analysis background and research background to older adult care. And so that's like where the journey really started.
Wow, really cool. So kind of going to you both again here, maybe a bit of a primer for folks. What is behavioral gerontology so people can kind of understand what this is all about?
Well, I mean, again, if we just keep it very basic, it's the application of behavior analysis and behavior analytic solutions to problems that might be commonly encountered in late life, right? The goal always is to maintain quality of life, to support independence. And so there's broad applications of behavioral gerontology, and working with older adults, there's a lot of different things you can do in the field, right? Because it's such a diverse and heterogeneous population. And I think one thing that not many people realize is how old behavioral gerontology is as a specialty. It kind of predates back to around 1964
Wow.
with Ogden Lindsley's chapter on geriatric behavioral prosthetics. And this idea that skill maintenance and accommodations and basically quality of life can be maintained through designing meaningful environments, increasing access to meaningful activities. And so that's kind of where behavioral gerontology started. And so while it's a field that still needs to develop, it's actually been around for quite some time.
What does it sort of, and how does sort of gerontology differ from geriatrics? Because I hear that term a lot too. Are they the same thing? What's the difference there? Do you know?
I don't think I think gerontology kind of encompasses all sorts of care. I don't quite know the difference between geriatrics and gerontology. That's just always the language I've used is gerontology. I don't know, Nehal, if
Gotcha.
you have a more specific answer.
Oh, yeah, to me, actually asked that question because actually I teach it to my students, but it's something when I worked in the field we weren't really, like I didn't learn that there was a difference. Technically, the difference is geriatrics is often employed in the application of medicine. So the use of medicine in treating problems and challenges experienced by older adults. So you often hear of like geriatric medicine. Gerontology is more of the social sciences, really, involving older populations. So whether that's the application of, really anything, psychology, any type of social science even, or the application of behavior analysis, anything that's non-medicine is from my understanding. Also, the word geriatrics is used to describe a population, and that depends on cultures as well. So I know in Canada, they kind of say 65 plus, but really working with older adults, I'm sure Jacqueline can attest to that as well. You see really 55 plus sometimes, although that's really on the younger end. But yeah, so from my understanding, that's kind of how it's used. So we say behavioral gerontology, but we work with the geriatric population. But geriatrics, I think, is kind of most often used in medicine, from my understanding.
I would agree with that. And I think even if we look at gerontology as the term, it's the scientific study of aging, right? So it encompasses researchers, psychologists, social workers, policymakers, people in public health. And like what Nahal mentioned, geriatrics, or the term geriatrics, is kind of that medical specialty and encompasses physicians who are geriatricians.
Yeah, and you touched Nehal on sort of ages 65, 55, whatever. Is gerontology is it about age, or is it about sort of body changes, cognitive changes that sort of happen? Because I know there are some populations. I mean, just one that comes to mind sometimes is Down syndrome. I know a lot of those folks tend to start getting into sort of potential cognitive decline really early ages. How does that all work? Is it an age thing, or what is it?
So I think, and this is me kind of just guessing, I wonder if it really started off maybe kind of piggybacking off of medicine, where maybe you do see certain maybe medical conditions present in adults at a certain age. But you're right, cognitive changes in individuals, dementia aside, just even natural cognitive changes that happen in individuals as they get older. And I'm sure Jacqueline knows probably a lot more about this than I do, but you see cognitive changes even in your face, for example, right? And it really depends on the individual, on their journey. So I do wonder sometimes if that special number of, in your 60s or 65 maybe started off based on what they saw in medicine, and that sort of carried over to other fields of work. But you're right in that if we look at it on the flip side, if we're working with individuals with developmental disabilities, someone's level of independence at the age of 27 could be I mean, the age when it comes to mental disability sometimes isn't always as relevant when it comes to specific goals, right? It really, you look at the person's overall presentation, what their values are, what's important to them, where they currently stand in life. There comes a point, in my experience working with individuals with mental disabilities, it's not so much about, oh, this person's 20, they should be doing A, B, and C, right? What is so socially significant to that person? But yet you're right. When we look, I think, at it on the other side, working with older adults, we look at it more of what are sometimes, and from a medical perspective, it's what are the deficits, right? At the age of 65, if somebody doesn't recall what they did that morning or a conversation they had just last night, that might be a reason to maybe be concerned, right? So I'm kind of going on a tangent here, but yeah, I do think that I wonder if it came kind of from the field of medicine, but I don't think there really is an age in my experience. I have worked with individuals who were in their early 50s and actually were diagnosed in their 40s. But because I worked more on an inpatient unit, obviously being someone, if you get to a point where you're being hospitalized, at that point, you're likely not in the early stages, right? There probably has been a progression. But yeah, these individuals were actually more rare cases, but had really early onset, let's say Alzheimer's disease, and were diagnosed in their even late teens, which is more rare. So you're right. So even in healthcare, where you have those criteria for admission of 55 and up for, this specific unit, or 60 and up, you even see hospitals can't really adhere to it strictly because there are cases somebody's 52 and they meet all the criteria and they need that help, right? And so I don't know if Jacqueline has any similar experiences.
Yeah, I think like what you're touching on too is this idea of like chronometry, right? This idea that we are guided by numbers. And it really is just this arbitrary social construct, right? These
Yep.
benchmarks
Yep.
of age, right? By age 18, you're considered an adult. In the US, at age 21, you can drink, you can purchase alcohol. At 25, you can rent a car. At 65, you can retire. You're considered old. And so it really just impacts how we interact with our social community, right? And it results essentially in this differential access to resources. And there's these social expectations and the way we're treated and how we talk about aging. And so I do know like this cutoff age of 65 has historical roots that can be tracked back to, and I'm referencing a page because I talked about this in a presentation once. So I'm not just pulling it out of thin air, but it can be traced back to the establishment of social security programs and retirement policies. And so this age at the time was chosen based on life expectancy estimates and the belief that individuals would typically not live much beyond that age. And so it was primarily targeted towards industrial workers and aimed at providing financial support during the last phase of their lives. And so when this cutoff was created, less than 5% of the workers were still alive. So very few workers actually got support during these last phases of their lives. And it was just adopted by many countries and has had a lasting impact on retirement policies and this perception of old age and a marker for old age as well. And also kind of promotes ageism, right? There's this cutoff. This age you're considered old, or you have these access to resources when some people might not need them and some people might need them earlier. But it doesn't necessarily reflect kind of the biological or psychological realities of aging for all people.
Yeah. Because I think about we have these terms for medically for age groups of pediatrics, for example, and I think we have some terms for the really little ones that you folks might be familiar with as new moms, but then when kids become adults, they're just adults, and then somewhere in there, it becomes geriatrics and gerontology. But it seems like really a lot of the things you do in the field could be applied to people of really any age that maybe aren't living with their parents. Or maybe even are living with their parents. That's not even a thing, right?
especially now, trying to buy a house, you're gonna live with your parents for much longer.
Yeah.
But yeah, like aging doesn't start at 65, right? Aging starts much, much earlier. And when we talk about age, what we really mean is health, right? We assume how healthy someone is based on age.
And so is the field maybe more than connected to diagnoses? Because you mentioned a few times how when people are getting diagnosed with early onset Alzheimer's or dementia, even as early as 40, is it when the body of course, some people, I've read like osteoporosis starts at like age like 25 or 30, or, it's sort of your bones start breaking down pretty early on in life. And so is that when aging starts? And is that when gerontology comes into play? Like, yeah, again, it's still that time construct, I guess, right? So,
Yeah, it's hard to kind of pinpoint it. And again, I don't know if the main purpose of this field is diagnoses, right? I think if we think about, what accompanies aging, oftentimes we see a loss of reinforcement, right? It's very hard because of, some of the changes that occur as one ages, right? Like you said, osteoporosis or arthritis or orthopedic problems in general. Someone who was an avid skier may have a harder time skiing now, right? And there's that loss of reinforcement there. And it's how can we maintain access to reinforcement perhaps in a different way?
yeah.
How do we continue to live in line with our values as we age, despite some of the changes that might come with aging? So I think there's a lot beyond diagnosis. I think that's definitely a part of it. And that's where geriatricians are incredibly useful, right? To help with the diagnosis of medical conditions or certain chronic conditions that tend to co-occur with age, or the diagnosis of neurocognitive disorder. But I think, that's not considered normal aging, right? Neurocognitive disorder. Cognitive loss is not normal aging. And so if we think about the majority of people as they age, how do we best support those individuals who don't have those diagnoses?
And so I think maybe this, it's kind of the loss of reinforcement piece I really like. And maybe this starts to be where we differentiate, because gerontology itself is just a field and is an area. And then there's behavioral gerontology. So what's the difference?
Well, if we think about the term behavioral gerontology, I think that was kind of coined by behavior analysts, right? So it's the application of behavior analysis and behavior analytic solutions to these problems that people encounter in old age. Whereas gerontology is just that more broad term that encompasses behavior analysts and social workers and scientists and researchers, other people who kind of make up this field of gerontology.
Do you have a certification with the International Behavior Analysis Organization, the Qualified Applied Behavior Analysis Credentialing Board, the Behavior Analyst Certification Board, or are certified through your region's Behavior Analyst Credentialing Board? You can earn continuing education units for this episode by going to www.behaviorspeak.com and clicking on CEUs. The first secret word is ageism.
Nehal, I don't know if you have anything else to add.
Yeah, no, I was going to say, so within gerontology, you find it's really an interdisciplinary field. So, for example, I've worked with a lot of really great social workers in gerontology, and they will work with older adults who we know that, for example, a lot of individuals, as they get older, there is an increased risk of facing challenges like depression or things like even untreated anxiety or untreated maybe mental health issues that have gone on for a long time that kind of need to be treated adequately. Things like loneliness, for example, managing changes in their lives, grief, right? Of course, as people age, many lose individuals around them. And so a social worker working in the field of gerontology, for example, would be, or even working with family units because of caregiving burnout, right? Things like that, right? Sometimes when you get older, your siblings are getting older, your parents are getting older, and then maybe your spouse is getting older, right? And so that, for example, is a social work type of role within gerontology. Then you have occupational therapists as well. And then you've got psychologists and behavior analysts. So gerontology for me is really an interdisciplinary field that just involves working with the older population. But there's so much that can be done. And like Jacqueline mentioned, behavioral gerontology is the application of and working with older adults. Jacqueline also mentioned earlier that it's true. It really can be applied to many things faced by older adults. Obviously, the reason why many of us work with individuals who have a diagnosis involves our healthcare system and what's funded, right? But you can work with a behavior analyst to target many different goals in terms of being an elderly adult, specifically things involving a lack of reinforcement, which could lead to a loss of independence, which perpetuates the cycle that many older adults face. Especially as we continue to live in a world that evolves very rapidly with technology, it becomes very hard for people to catch up, especially we've seen it during the pandemic. A lot of older adults became very, very isolated. In the context of gerontology, yes, many of us work with individuals who have dementia because that's where the funding is, right? That's where the medical need sort of is. Scientifically, yeah, we can work to target many, many different goals. outside of cognitive changes.
Yeah. And I would say if we think about behavioral gerontology, so in what areas can behavior analysts support older
Mm-hmm.
adults? There's the assessment and treatment of emotional and behavioral changes that tend to accompany cognitive loss.
Hmm.
That's definitely a part of it. I think that gets a lot of the attention for behavioral gerontology, but it's also just such a narrow focus or scope of practice.
Mm-hmm.
You could also, it's the general assessment and treatment of behavioral health problems, right? For the purposes of health promotion, disease prevention. So, exercise, diet, sleep, engagement in meaningful
Mm-hmm.
activity. It also involves designing social and physical environments. So, those prosthetic environments that, Ogden Lindsay had mentioned, and making modifications that allow older adults to maintain their independence, maintain access to activities, improve quality of life. Like this goal that a lot of us have is to age in place.
Mm-hmm.
That's a big initiative. And then there's also this idea of building novel repertoires in old age as well. Again, this might not be applicable for someone who has cognitive loss or a neurocognitive disorder. But again, the majority of older adults do not. And so this idea of building novel repertoires and also teaching replacement or compensatory strategies as well are, I think, kind of main areas in which behavior analysts can be really successful with this population. We have the skills and the tools to support those three areas.
Mm-hmm.
And there's also a lot of overlap I have found with rehabilitation psychology as well.
Mm-hmm.
And in terms of the work behavior analysts can do in older adults.
And so, what are some of the places? I like to think about this too, especially from the Canadian context, because you both are in Canada, so am I, and I don't get a lot of opportunities to talk to folks in Canada, the field in general. Where are behavior analysts kind of currently doing that work?
Nehal, I'm going to let you start this one only because I actually haven't been like working in the Ontario landscape for a while. I've been in Michigan doing my PhD. And so I'll be entering the work field and kind of seeing firsthand how it operates. However, I'll be kind of working as a clinical psychologist instead of a behavior analyst, using my behavior analytic background. But yeah, Nehal, I'd love to hear your experience working in Ontario.
For sure. So, I personally started off working with older adults in Ottawa, where I was there for a couple of years. And at that time, I really hadn't heard of anyone in ABA working with older adults. It was myself and my colleagues. I'm sure there were other professionals out there. I myself was new to the population. I would say the majority of the time, you will find us in healthcare settings, so in hospitals, or community organizations that work closely with hospitals. And so in my experience, I've worked in healthcare settings. That's where many of us are, both inpatient and there's outpatient as well. You'll see, and even while working within the healthcare setting, though, I very often was actually consulting to long-term care homes. Although I was employed by hospitals, the majority of my work was actually happening in long-term care homes. That was one of my positions. There's also many organizations that involve working with older adults that are kind of helping that transition from hospital to then long-term care. I have not heard, to be honest, and I may be wrong, they could be out there, but it's a lot of services that are available for maybe older adults that are still at home. But I think that's more to do with a flaw with our healthcare system, right? In that these services are there when it becomes really essential and where the person is at the point where they have to move into some sort of residential care setting. But I would say the majority of us work in healthcare setting or in community organizations to facilitate those transitions. Either the person's about to move from their home to long-term care or from their home to the hospital and then hospital to long-term care. So, for example, like in Toronto, Center for Addiction and Mental Health, CAMH, has behavior analysts working with geriatric populations, I think on their inpatient units. Ontario Shores, based out of Whitby, where I used to be, also working both in long-term care as well as inpatient units. I know in Kingston, Ontario, there's a hospital there that has a couple of individuals on the inpatient units that work with older adults. I can't remember the name of the hospital. But I know that. So yeah, and Ontario, I'd say from my experience, a lot of us tend to work in healthcare. We're not many, but I think we chatted about this in our other episode. I think with regulation, I've noticed that there's a bit more of a demand now for behavior analysts with populations in healthcare that you didn't see before. So I've seen more job postings and in healthcare settings for older adults. So we'll have to kind of stay tuned and see. But I would say the majority of us tend to work in healthcare or in organizations sort of adjacent to healthcare settings.
So tell me a little bit about ONTAB 2025. What's happening?
Our conference this year is happening November 6th and 7th at the Metro Toronto Convention Centre. If you're in Toronto, join us in person. If you're not in Toronto, join us anyways, because all of our rooms are fully streamed. They're all online. Through Behaviour Live, you can access every single one of us. Plus, if speakers give us permission, we'll record their sessions. And then they have our speakers this year. We have Mark Lenovas as a Canadian speaker. We have Ryan O'Donnell, or Ryan O. He'll be one of our speakers. Holly Gover, who's attached with FTF, will be one of our speakers. And we have Ali Kazemi coming to speak.
Wow. I hope you'll join me at ONTABACon 2025, November 6th and 7th in Toronto. Better yet, come find the Behaviour Speak booth and be a guest on the podcast. Get 10% off registration using the code BXSpeak10. That's BXSpeak10.
Yeah, I know another common organization that has a team of behavior analysts is Behavioural Supports Ontario, and they do a lot of care for older adults who have responsive or challenging behaviors. And so there's a team of behavior analysts there. They're interdisciplinary outreach teams. I know there's some behavior analysts working for BSO at Baycrest in Toronto as well, and they're a big hospital for dementia research and care. And so I know that's where, if you're interested in kind of assessment and treatment of challenging behaviors associated with dementia, that BSO or Behavioural Supports Ontario is another area you can get involved. One area where I don't think I see a lot of opportunity to work is this idea of how do we support older adults in the community? Right? I think we see a lot in like long-term care and more acute issues, acute problems, right? Like BSO, they kind of work with older adults with challenging behaviors or inpatient. And so I think that's an area where there's a lot of opportunity, but I don't know of anything at the moment. Because majority of older adults do live in the community and do live at home, right? And how do we keep them there and prevent them from going into, inpatient settings or institutional settings like a long-term or assisted living facility? And so I think that's an opportunity. But again, Nehal mentioned too, I don't know if there's necessarily funding, right, for that right now. And I'm not familiar. So there may be, but I'm not overly familiar with all of the funding initiatives in Ontario at the moment.
Yeah, there's none that I've personally have heard of. And my years working with older adults, I may be mistaken. I would imagine if that's the case, it's more of a private agreement. Even like an example of the changes we've seen, like BSO historically, when I started with older adults about 6 years ago, was predominantly people with nursing backgrounds and social work backgrounds, occupational therapists. And now today you're seeing them working with behavior analysts. But I remember back in like 2019, my position at the time was funded by at the time it was called the Local Health Integrated Networks in Ontario, but by the BSO initiative. But we were strictly in hospitals. And so, but now you're seeing more and more of behavior analysts. So there's definitely a lot of progress. But yeah, I don't know if we have that similar to the way we'd have it for individuals, maybe with developmental disabilities, where some supports could be available at home to at least maybe prolong how long this individual can live in the community for before they have to maybe go into long-term care. I don't think we have that quite yet. And if we do, I haven't personally met behavior analysts that do that role. Perhaps it's individuals from other disciplines.
Yeah, it's this like prevention approach, right? Versus this reactive approach.
For sure, yeah.
But I think, like you mentioned, I'm hopeful that we'll continue to see growth in the area, especially with these changes in regulation, like what's happened in Ontario, and just opening up more avenues for behavior analysts to get involved in gero work. I think another thing, if you do a job search and search, for behavioral gerontology jobs, they're not going to pop up, right? You have to look for different key terms. And I think at the end of the day, it's about how can I bring in my knowledge of behavior analysis and behavior analytic strategies to support individuals who may engage in problem behavior, for example. So it's sometimes though we're bringing your skill set and your training and your knowledge into a different role as well.
So are some of these jobs then jobs that maybe you aren't specifically looking for a behavior analyst, but you're sort of like, my skills could be applied to that job and I'll pitch it to you, or are these folks looking for,
I'm not entirely sure. I do know there are teams of behavior analysts, like at BSO, for example, and I think it's their, the value of behavior analysis is definitely known. But I'm not quite sure kind of what the landscape looks like in terms of how to apply and what they're looking for specifically.
I would say
Mm.
that today they probably listed Ontario now know to they'll sort of
Mhm.
look for behavior analysts. You'll see that. But I would say not that long. I mean, I say long ago, but like 6, 7 years ago, perhaps it was individual. And I mean, I will say when it comes to behaviors, there's other disciplines that have their own way of working with individuals who have challenging behaviors. And sometimes it may not be the same as us. And sometimes it actually couldn't work quite well together. But I would say there probably was a time where, Ben, like you said, it's people would kind of work in teams to help manage behaviors, but not from a specific lens or a specific discipline or specific science. Now you're seeing them actually ask or requesting people, or I would say sometimes employers don't really know what ABA is. And so you'll see a position posted, but based on the job description, you may have an idea that they may not be quite familiar, right? They'll say, using modalities like CBT or other regulated sort of modalities in Ontario that we don't use in ABA. So you can see that they're kind of trying to hire behavior analysts, but they're not really quite sure what we do. And I'd say probably with older adults, it's one of the bigger challenges is if somebody does go on to work with older adults, you're kind of typically the one on your team that knows ABA. Rarely do you see, like I remember I used to work in an autism program. Even though I had my own caseload, it was myself and multiple other colleagues in an office in a program, and we were all had kind of ABA training. Whereas I found that the more you work with these populations that aren't the most common, you're the one person with the background in ABA. Then you've got maybe the psychologist, you've got the OT. It's rarely you and 2 or 3 other behavior analysts that have that training, right? And so all that to say is I think today organizations are trying to hire more behavior analysts, but you could see by the terminology and they're still learning themselves really what we do.
Right. And to your point, Nehal, when you're working on a team of other disciplines, right? Everyone kind of has their own ethics code and, training and approach. And, in a perfect world, those all marry really nicely, but there's going to be some, some opposition or a difference of opinions. And that's just like an added layer of, I guess, complexity when working in the field. And that's across the board, right? With any population in general. And I think, behavior analysts have a lot to add, and I think they can be a really great addition to those teams. And it's just kind of figuring out how they work
Mm-hmm.
with those other stakeholders.
And what's that been like for you now in terms of collaboration and as far as sort of acceptance of having a behavior analyst on the team?
I think I've had a pretty good experience. I have had colleagues who've had mixed experiences, but I think it depends on so many things. For me personally, it was much easier to have that success working on an inpatient unit. Simply being is that you're there full time with the same
Right.
colleagues every day. You can build
Yeah.
that rapport and that trust and really work closely together as a team. It was had 10 long-term care homes, for example, under my
Mm.
caseload, right? And
Mm.
you go in every day and you're lucky to come across the same staff twice in a row, right? But I think overall people were open to it. I think though there is a lot of discussion that needs to be had about sort of ABA, the principles of behavior, all of that stuff.
Mm.
One of the biggest challenges in healthcare settings is finding time, sorry, I should say, to get frontline staff off of the floor, off of just give them a break from their main duties to sit there and chat about the clients, the patients, talk
Mm.
about data collection, provide that really solid mediator training. And we all know, I mean, our healthcare systems, it's really stretched thin. And so nursing staff could have, I mean, a long-term care home, it was like 20 patients under that they're responsible for. But even in inpatient units, if they have 5 patients, they have a lot going on. And these patients need eyes on them at all times. And so I can't simply go and get my nursing colleagues off the floor into a meeting room, have a nice PowerPoint
Mm.
presentation, right? And so I think that's one of the biggest issues with our system, and I'm sure that's a problem that's seen in many other healthcare systems. And I wonder sometimes, I can only imagine that success that we talk about. Like, I think behavior analysts will have a lot more success in these settings if we had that time to build the rapport
Mm.
and actually contribute, right? But I think that issue is seen system-wide across other disciplines that provide that sort of training and stuff. It's just very hard, I would say, in a quick 15-minute rounds talking about patients on an inpatient unit to then chime in and discuss the behavior plan. But I would say I've had success. People are definitely open. I think data is very novel in these settings still, and I don't blame them. You're not used to kind of finding, and you do have to find really creative ways of collecting data. Long gone are the days of using a clicker to calculate frequency of a challenging behavior when you've got an individual who is in a lot of distress but also has very high risk behaviors, right? You just can't really stop what you're doing and start counting, right? And so I would say you're really just a part of the team at that point. And you've really also got to work on your crisis intervention skills, is what I would say, especially on an inpatient settings where individuals are a lot more vulnerable and they're going through a lot. It could be quite unpredictable. But I've had quite a bit of success. And just to add one more thing, we were talking earlier, Jacqueline was mentioning rehabilitation psychology. Like I've worked very closely with physiotherapists, occupational therapists on things really unrelated to what you think of classically as challenging behavior or responsive behaviors, we look to call it in dementia, but even things like how do we increase motivation for patients to start walking? So physiotherapists deem that a patient is physically well enough to walk. How can I work with them to just increase that motivation? Because maybe that's a requirement for them to be able to go back to living in a group home setting rather than go all the way to long-term care. To be able to go out with their family or to be able to go on outing. So all of these things I've been able to target. So overall, I've had really good success working with OTs, PTs, social workers, nursing staff, and psychiatrists as well. But if there has been a challenge, it's more so about the limitations of our system.
I would agree with that too. And, I like how you mentioned your collaboration with like rehab specialists as well. I worked for a year, did a placement at Michigan Medicine in their outpatient neuro rehab unit. And so that was a lot of interdisciplinary teamwork, working with OT, PT, SLP, psychology. Obviously, there weren't behavior analysts working there per se, but a lot of my role was behavior analytic, the work I did. And it often was, I think, our training and our background, we learned to take this contextual approach, this bird's eye view on our client's life and consider all relevant contextual variables. I think we have a unique skill set in that we can really help identify barriers, assess the function of challenges and problems that might arise in someone's rehab plan, for example. What's getting in the way of progress? What are these barriers? How can we address these barriers as a team? And how can we support these other providers in addressing these barriers? Or perhaps I jump in and then I do a couple sessions with the client and we do some problem solving together and some goal setting related to their physio plan, for example. And so that's been really nice to see how that collaboration can help. But again, it's not, that role isn't written out per se, right? That's just something you come across working on a team, and how can I be useful here? And I think us being kind of natural investigators and learning how to take this like contextual approach on people, especially with older adults or adults in general, we come with complex, rich histories, right? There's a lot of factors and a lot of contextual variables that can influence someone's performance and someone's behavior and someone's progress with rehab, for example. And I think that we have a really useful role to like keep all those moving parts in mind and help the team become aware of the larger context as well.
Wondering about, because you talked about a lot of the work you folks do are in these institutions, in these residential facilities and whatnot. Do you think that a big part of the reason why there's challenges in the first place is due to them being in these facilities? They don't often end up in the facilities that maybe because of challenges. They end up because of maybe more safety reasons or memory issues and things, and unable to feed themselves or whatever it is, just things that make it a little more difficult for them to care for themselves, and then they end up in an institution. And is this where sort of that loss of reinforcement starts to happen more?
Yeah, I think you definitely have touched on it. I am a big predictor of placement in long-term care is also caregiver burnout, right? And so especially if you have a caregiver who's still working and maybe also caring for their own children and caring for their aging parents, it can be a lot. And so if I know the transition into long-term care, I mean, this would be for anyone, right? You're going into a new living environment. Nothing's familiar. Those SDs, those cues that might prompt behavior once are no longer there. We might see further breakdown, further repertoire decline, for example, in those new environments. I think that definitely can be can set the occasion for increased problem behavior, right? And yes, sometimes it's necessary if safety is at risk. So I think the environment does definitely play a role, right? And if we even think about someone who with neurocognitive loss, who's in a new environment, things are unfamiliar. And then, they once had agency over when they wanted to shower, when they wanted to eat. And now they're on someone else's agenda and someone else's timeline. That's really tough, right? And that would be tough for any of us, especially if there's no insight there and they don't understand. Or even not to mention, let's say there's this unfamiliar staff who's asking you to shower and take your clothes off and get in the shower, right? When that's a very private behavior. And so a lot of the times when we see aggression, we have to reconceptualize it as it's self-protective, for example. So yeah, I think that change in environment and all that comes with it definitely can be a cause for some of these behavioral changes. Again, we're behavior analysts, so we don't attribute these changes in behaviors to the changes in the brain, right? It's what's happening in the person's environment, their context. What is the function of those behaviors? It's not just because they're getting older and their brain doesn't work like it used to. Reconceptualizing things. So even things like wandering, right? That's a common target behavior in these environments. Again, let's kind of switch gears. It's seeking meaningful events. Someone who used to go on walks every single day and then now is in this place and doesn't have access to going on their walks, and they're exit seeking. Maybe they're just trying to access outdoors and go for a walk that they used to, right? They're used to trying to maintain this routine. And so again, like reconceptualizing some of these like common problem behaviors. And I think what's also really important is asking yourself, for whom is it a problem? That's huge.
And that's what I was kind of wondering about was, is it sometimes that you're asked to kind of come into a case because these folks aren't behaving in a way that fits into the structure, the system that they're in, and we need them to sort of do these things in order for the nurses to, get their job done and others to do their thing and other patients to, have their privacy or whatever. Is a lot of your work trying to help them conform to this systemic problem? And kind of related to that, because what I've been thinking a lot about is, so I work a lot in group homes for adults with intellectual disabilities, and I talk a lot about sort of the group homes were sort of a result of deinstitutionalization, and so kind of pulling folks out of these larger hospital type units because of all the problems that were inherent in there. Have we learned any lessons from the past and in sort of these contexts, and do some of our ethics kind of come into play where we start thinking about the kind of work we're doing in these institutional settings to sort of, how do you balance all that?
It's really tough, right? There's, at the end of the day, these individuals, they're there, whether safety be a concern, right? And there are these major systemic constraints and barriers. There's only so much we can expect from staff, right, on day to day when they're burdened and there's not a lot of support. And yes, right, there's some serious quality of life considerations. A lot of domains to consider when someone's in a nursing facility or a residential home, for example. And so it's a really tough balancing act. And it's up to the staff, right, to make that difficult choice between going with what's expected by the institution or doing what's really meaningful and important to that particular client. And I think maybe just starting to have conversations around what quality of life domains are being met versus not. It doesn't mean it has to be acted on right then and there. But again, just starting conversation around how can we problem solve? What slight changes can we make or propose? I think the best that we can at least start by doing is just recognizing what areas are unmet and how can we start a conversation around that? And Nehal, again, in your experience, I'd be curious to hear how that might be directly addressed?
I think it's a very loaded question because I think a big thing to consider too is culture, right? Culture dictates a lot of different things, whether it has to do with our eating habits, our daily living skills, our interactions with other individuals. And so, for example, I think of a client that I had once, and you often have these discussions, kind of like Jacqueline, actually, she kind of, her point about in behavior analysis, we look at the contextual piece, right? Sure, yes, this person has a cognitive disorder. Of course, that may lead them to perceive reinforcement differently, but regardless, we still have to implement some sort of contingencies in place to help mitigate some of the challenging behaviors. But this one individual, I remember in a common conversation in psychiatric settings is, let's say person's name is Robert, for example. Oh, Robert's really declined cognitively. He's really declined. He didn't recognize me the other day and he usually recognizes me and this and that. And it's often this debate of he's declined, right? And yes, it is it's a progressive illness and there will be some decline when you work with people with dementia. But I remember one time we worked with an individual who was having a lot of really challenging behaviors, the context of getting his daily care. So at that point, he'd been experiencing incontinence. And so he was no longer able to use the toilet independently, recognize when he needed to go to the bathroom. Showers were also very challenging. Sometimes it was 5 individuals with this one person. Never in anyone's life, typically speaking, do you have 5 people with you in the bathroom, right? At any given time as a child, as a teenager, as an adult, right? So that already is very traumatizing. But I remember there came a point where there was that discussion about cognitive decline, but then interestingly enough, that person one time, just like Jacqueline was saying, like obviously the behaviors are a response to what's happening around them. Because if you leave them be, they're not engaging in responsive behaviors. Typically, they're not usually going to seek you out, right? So it's responsive. But the person was no longer engaging in those behaviors during bath time, and they were saying, well, he's doing so great. He's no longer striking out. But the thing is, it wasn't that he was doing so great. Unfortunately, it's because the degrees had progressed so far so that he was no longer striking out, which, of course, I'm glad for my colleagues that they were no longer getting hurt. But I think we didn't recognize that it was almost he didn't recognize what was taking place around him either. And so you have these kind of complicated situations where it's the decline in and of itself sometimes causes changes perhaps in the behavior, more so because, again, that SD, right, that would evoke some of those behaviors is no longer evoking those behaviors anymore. They're not recognizing that somebody approaching you and helping you remove your clothes, they don't have that sort of we call the fight or flight mode anymore because they're not recognizing that as danger. But again, to your point where you mentioned the system, yeah, very true. I remember one time, one of the points of discussion was there was an individual who liked to take long showers and he was fairly independent with a lot of his steps. But of course, for safety reasons, they had to set up the shower for him, check in on him, etc. But that was one of the concerns is he takes 45-minute showers. And then in the same meeting, there was a complaint about another individual who hadn't showered in 3 weeks. And so it's like, it becomes really complicated, right? What routine, and the routine in one institution, he could be discharged to long-term care home. And all of a sudden their showers are maybe different frequency per week, different duration. And so would it not just be a lot easier that we try our best? I know it's impossible, but to maybe adapt to that person's needs, what's important to them, what routines are important to them, how often did they shower previously? And sometimes too, it becomes even more complicated because maybe somebody did really enjoy showering for a long time or take 2 showers a day and then their spouse really advocates for that. Maybe that person is at a stage in their life where those things are no longer meaningful to them. And maybe we're also trying to enforce something that the family expressed was meaningful. And now that's leading us down a whole other set of challenges. If that makes sense, I don't know if I'm, so I think it's a couple of things. We're trying to maybe fit that person into sort of the constraints of the system, but then maybe sometimes we're trying to maintain something from their former lives or their lives at home that no longer apply. And we also have to recognize that person is always evolving. As individuals, naturally we evolve, right? I'm not the same person I was 7-8 years ago, but then you add in sort of a diagnosis, a neurocognitive disorder, they evolve in different ways. And I think that the biggest challenge is that as professionals, we need to adapt. The person they were in July may not be the person they are in October. And as long as it's not causing any safety issues, as long as they are able to maintain a certain quality of life and there are no healthcare concerns, we need to be really, really adaptable. And it's hard to adapt in a setting that has been going through a crisis for a really long time, right? Healthcare, even I think COVID magnified a lot of the issues in our healthcare system. But yeah, how do we adapt? I think that's where the complicated questions come up, right? There's so many limitations, so many restrictions, and we do our best. But like Jacqueline's saying, right, we look at those domains and what's important to that person. What do they need to ensure safety, security, and how do we even measure happiness and satisfaction, at least from a behavior analytic perspective?
Yeah, there's an article by Rosalie Kane and colleagues, and it essentially discusses kind of various quality of life domains for older adults living in nursing homes. And for each domain, there's example questions that you can ask residents or kind of the care team to further assess the meaning and value for the person, right? It looks at things like physical comfort. Are they free from pain, functional competence, privacy, autonomy, dignity, a various list, which really are kind of fall under basic human and patient rights at the end of the day. But again, I think going through that as a checklist and making that part of the process, right? And to start those conversations and asking these questions in an open-ended way so you can identify areas for improvement and then just know how to best support your clients. And again, like Nehal mentioned, it's important to find what's meaningful for your clients, and what is meaningful may always shift as a function of the environment. So, maybe after moving into long-term care, someone may actually start to value the ability to make their own choices, such as when to eat, where to eat, when to shower, right? All choices that are oftentimes stripped away when someone moves into long-term care. And so what's meaningful may shift again the following month, for example, once they become more accustomed to the routines there. And so it's really important to always reassess meaning and values, and consider the individual's history and the role that plays as well, and recognizing the challenges that come with assessing meaning in long-term care settings as well, right? Because there's this assumption that older adults should fall in line with the rules of the facility.
The second secret word is care.
All right, the conference, 14 breakout sessions that we have available throughout the days. Ignites are coming back this year, and Ignites give people a cool opportunity to share something different. So we have about an hour worth of Ignites happening. We have vendors offering job opportunities, offering discounts, etc. We have a social event. There's really a lot to do, especially if you're in person. And I think this year you're going to be coming and joining us.
That's right. Yeah, I'm going to join you folks for the first time ever. I'm super excited to go to the biggest ABA conference in Canada.
And we're super excited to have you. And I think there's a little rumor going around that we're going to have a live recording of an episode for your podcast.
Yeah, this is Behavior Speak all weekend long. That'll be a first for Behavior Speak, a live episode. And then also I'm going to be there setting up shop and doing live interviews with all the attendees that want to come see me, with speakers, with organizers. Yeah, it's going to be a lot of fun. I hope you'll join me at OnTabacon 2025, November 6th and 7th in Toronto. Better yet, come find the Behavior Speak booth and be a guest on the podcast. Get 10% off registration using the code BXSpeak10. That's BXSpeak10. I love that. And I was going to ask a bit about sort of, where kind of cultural responsiveness kind of comes into this as well. And I think you've touched on that a lot there with sort of the values-based approach and whatnot. Wondering about, you talked about, I wonder, something I hear a lot about in is sort of this, and it's there's sort of this sort of, I don't know, sort of narrative that older adults, the decline is kind of compared to sort of a, kind of the whole Benjamin Button thing and kind of returning back to kind of childhood, which I think has there's a problem there in sort of, because now we're just infantilizing them just like we did do with a lot of kind of adults with intellectual disabilities. But we do see a decline in, functionality and life skills and access to reinforcement and things like that.
Again, this is why it's so difficult. We can't, if, working in the field of ABA and autism, for example, it's not a direct translation to working with older adults. One of the main differences is, again, older adults have rich and complex histories, highly verbal people as well. And that history is going to pop up time and time again,
Yeah.
even as we see brain changes and even as there's repertorial decline.
Mm-hmm.
And that's something we can't lose sight of as well.
Yeah.
Again, all behavior makes sense in the person's context and
Mm-hmm.
in their history, and we don't want to lose sight of that. And so it's not that they're just regressing to a childlike state,
Mm-hmm.
right? And I think it's just recognizing too, like, yes, we see repertorial decline, we see breakdown in like behavior chains, right?
Mm-hmm.
The consequence for one step of the chain is no longer serving as an SD for the second part of the chain. How can we identify the breakdown, and where can we supplement to support that person and maintain independence rather than step in and do the thing for the person, right? Further kind of reinforcing this like narrative that maybe they need the help or they're incapable,
Mm-hmm. Mm-hmm.
they're an infant, right? That they need to
Yeah.
be cared for. Because at the end of the day, having that mindset, I think it just further leads to excess disability for the person.
Mm-hmm.
And I think that's extremely common for individuals with neurocognitive loss, is this idea of excess disability. And we want to prevent excess disability. And there's also so many rule outs, I think, that need to be done before we kind of hang our hat on this is because of the cognitive decline as well.
Mm-hmm.
And I think the cognitive decline and the dementia diagnosis tends to really overshadow all that else is going on with this person.
Mm-hmm.
Medically, for example.
Yeah.
And I love that. And so what are kind of some of the tools that you have that behavior analysts can use to sort of do this kind of assessment? What does assessment look like?
Assessment of what?
Well, sure. I guess I don't know. I'm curious to sort of what about sort of some of the different tools you use in your work that maybe behavior analysts might not be familiar with.
Well, I think, let's say, for example, someone is coming in or they've been referred by a family member because they have concerns about cognitive loss or cognitive changes. I think that's very common, right?
Yeah.
Someone might come in and say, I'm worried I have dementia, or I've been noticing difficulties with my reasoning and my problem solving, or I'm forgetting things, right? And I think, yes, we want to rule out cognitive changes or rule in cognitive changes as a possible explanation. But we also want to look at, like, I think there's this checklist, right? We want to look at their medical status. Do they have pain? Are there any other chronic medical conditions that are occurring that are potentially unmanaged? What sort of medications are they on? Is there substance use? Especially in Canada where our cannabis is legalized, we definitely have seen an uptick, especially among older adults who regularly use cannabis, which again can affect cognition. A really big one is also uncorrected sensory loss. Are they getting their eyes checked, their ears checked? Are they using their hearing aids, right?
Wow,
Hearing
yeah, of
loss
course.
in
Yeah.
midlife is a pretty significant, not significant, but it's a pretty large predictor of dementia and cognitive loss as one gets older. Well, delirium is another big one we want to rule out, oftentimes due to illness or infection or medication, for example. So I think, like, one of the first things we want to do is detect these changeable factors and make sure there's nothing else going on. And then we want to look more broadly, right? Look at their social emotional context. What's changed for the person? So for example, I had a client come in with these concerns, and they also recently retired. There was a big shift and change in their activity pattern. They didn't know how to spend their days. There was kind of that loss of positive reinforcement in their day to day. They had a hard time managing their time and knowing what to do with themselves, essentially. Also, if someone's a caregiver, that can also cause a lot of mental health problems, right? If there's depression, a lot of the times those can present very similarly as a dementia presentation, especially early on.
Wow.
And so I think just the rule outs and these changeable factors and modifiable factors are really important to assess, because oftentimes, again, this is very ageist, but it's common where we incorrectly assume problems are a function of getting older or a
Right.
function of age, or we just hang our hat on this dementia as the problem, and we overlook so much more.
I really love that because it reminds me of a conversation I had, or I have often, like, with my parents, and I think it's a bit of a cultural thing. And I don't know if others can relate. My parents are, they're elderly, they're in their 60s and early 70s. And the idea of, and I think it is a cultural thing too. It's, I have knee pain and I used to use the example of my colleagues. where they're like, well, no, it's because of the disease. And it was really like, we're just kind of speaking in circles. Yes, the person does have a certain disease. Yes, of course it contributes, right? But like Jacqueline said, we have to look at the contextual factors. And so the example is I have knee pain. Well, that just comes with old age, right? I said classic discussion. I'm sure I had a discussion 2 days ago with my parents, but well, it's just my back hurts.
I'm getting
Well, it's because
old.
I'm old. Right, but what about you being old caused your back to hurt? Because people are in their early 20s, and if their backs hurt, you don't say it's because I'm old. Could be because I'm a football player and I play competitive football and I was tackled the other day and now I have back pain and we really investigate, but we don't. And today it's because I'm old. And what does that reinforce? Well, let's say my knees hurt because I'm old. Well, therefore, if I'm old, I need to walk less. Otherwise, it'll trigger my knee pain. Therefore, I walk less. But then I walk less, I exercise my knees even less. And so I'm a lot less mobile. I'm a lot less agile. But then my knees continue to hurt at any sort of movement I make. And well, then maybe I need to stop using the stairs. Well, maybe I need to stop going for my walks. Well, now I'm isolated. Now I'm home more often. Now I don't get to go see my grandkids more often. And then you kind of start seeing those cognitive changes come about even just from that, right? And so the idea isn't so much that your knees hurt because you're old. Your knees, and they may, right? But there's wear and tear, and maybe you were an athlete once upon a time, perhaps. But generally speaking, your knees hurt because your lifestyle has changed as you've gotten older. Let's look at the contextual piece. It's the same idea with dementia. Of course, there's a diagnosable illness. And of course, the person's challenges maybe would have been totally different had they not had this diagnosis. But regardless, there are things happening around them that are evoking some of these behaviors, right? With dementia, there's that faulty stimulus control, right? DSD that would have otherwise led to certain behaviors, that sort of communication is no longer happening. It's how I often explain to my students, right? There's a breakdown in communication. And so if we often just say Robert is experiencing this because he has Alzheimer's and that's how it is, there's a lot. I mean, you're setting yourself up for a lot of other challenges that will really snowball into other things down the line. And so I often like to use that example to, if we're working with somebody who maybe has more of that medical mindset of, and it's same thing. I mean, we would never use it in the world of autism of this person experiencing these issues. Well, because challenging behaviors come with autism. Right? But if that was the case, wouldn't we see these behaviors? The person has autism 24 hours a day. It's an ongoing diagnosis. We don't see it 24 hours a day. Therefore, there's things in the environment that evoke certain behaviors, and we have to kind of work with that, right? Same if we look at it from a skills-based perspective. Why are they losing these skills? Yes, we don't expect individuals to maintain the same skill level living with dementia for a period of 5-10 years. But if they're losing it at a certain rate or something's changed overnight, like Jacqueline said, a common thing is delirium. And even in healthcare settings, that's an increased risk factor, is being hospitalized, right? Acquiring certain hospital even based infections, things like that. Urine testing, making sure they don't have a UTI. It's a very common picture for delirium. And so and that's one of the things too, right? In older adults, delirium can lead to irreversible cognitive changes if not treated promptly. So we may think it's just a UTI, maybe a UTI for a 20-year-old, but for somebody who's 7 years old with frontotemporal dementia, Alzheimer's disease, it needs to be treated and quite promptly. And so sometimes you have that disagreement too, and where they say, and that's where we go back to operational definitions and trying our best to operationally define these changes. You'll see one individual saying, well, Robert, his ability to concentrate is really different today. He has a really hard time concentrating maybe on the recreational activity. He often can sit down and play this game for much longer. And someone else says, well, no, I mean, he has Alzheimer's. That happens, right? And if we look at a way of operation defining these changes, we can actually then, or measuring these changes as well, we can actually recognize when is it really just the dementia progressing, or are there actual changes that we need to look at? And so, because like Jacqueline said, it's not just ruling out medical at the beginning. They have to continuously be monitored for these medical changes as well, because that's when you really recognize, because sometimes otherwise there's a lot of things that can be swept under the rug as, it's just dementia, and then it's something else, and you leave that untreated and it can snowball into something a lot more serious.
I also I love the example you use with knee pain, because I think it just, again, this narrative, right? Oh, I have knee pain because I'm old. It just, again, further reinforces this idea of overlooking modifiable and changeable variables in someone's environment. Is it knee pain, or is it because you're sedentary or you're overweight or you have muscle loss or there's osteoarthritis at play, all of which can be addressed with health behaviors, right? And this idea that, and there's this, again, this narrative as one ages, this is just my fate. There's no point addressing these health behaviors because this is just my fate. Whereas if you help the person establish an exercise routine, slowly build muscle loss, pacing, all of those things and actually help manage the knee pain.
Really, it sounds like we also need to have a lot more conversations around ageism. It seems like there's some really good conversations happening in the ABA field around ableism when it comes to sort of, we talk about sort of, that's because he's autistic, he's engaging in challenging behavior, and we're trying to move away from sort of that language. It sounds like we could have all those same conversations and just replace the word ableism with ageism, and it's all sort of those same problems.
Yeah, myself and a few others within our lab, this was about, I want to say 2 years ago, we gave a talk at IBAI, a workshop actually on ageism, so aging in behavioral health essentially, and talked about various points of advocacy for older adults and various common misconceptions about aging. And it was really well received. And I think one of the big takeaways is, again, everything we discuss can also be applied to individuals, adults with neurodevelopmental disabilities as well. And then there's this really interesting overlap where adults with neurodevelopmental disabilities then start getting characterized as having a neurocognitive disorder, right? And I think the risk in that is, again, we're overlooking these modifiable and changeable factors in the environment. Is it dementia and decline, or are there all these unmet needs? Is there pain, right? And then add in difficulties communicating, add in like a history, right, of not being able to communicate one's needs. I think that's where it can get really tricky as well. And that's where it's really important that we advocate for these individuals. And we recognize kind of all of the important rule outs and how to best kind of approach a behavior problem rather than just say it's due to a disability or due to a diagnosis of dementia.
Yeah. With all these rule outs, I think be really powerful for people. Keeping all those in mind, are there conversations in the field around prevention? Sort of, how can we, like you said, how can we keep folks at home by maybe addressing some of these things early on or providing education? But I just think about even me, like I work I volunteer as a first responder. And so I have an opportunity to be in the homes of a lot of elderly folks and who are struggling with disease and disability. And it's been I live in a small town, very small, like 800 people. And so these are my neighbors. These are folks I see on the street every day, or folks I never see on the street. Now I know why. And it's given me a lot of pause and time to reflect. And I turned 50 last year. And so now I've started really revisiting my health and learning that the way these folks are isn't inevitable, and that I can do things. I want to be able to walk. I have a family member who has the scoliosis, very bent back kind of deal, and my wife picked up on early on that I had really horrible posture and said, you need to straighten up or you're going to be like them. And it was a real kick to sort of start getting into physical activity and start doing kind of functional exercises and things. And the motivation for me now that I'm a bit older is so that I can stay like this 20 years from now, 30 years from now. Are there conversations like that happening in the field?
I think that's always a focus, right? Like prevention, health promotion, disease prevention. I know, at least in like a lot of the work I've done, and again, like this kind of is a crossover and like I do a lot of psychotherapy with older adults as well. There's a large focus, at least initially, on like values exploration in order to kind of set the stage and then have that lay the groundwork for, what's important to you as you get older. I've worked with a lot of clients in their 80s and older, and the conversations are very much around how do you want to live the rest of your years and what do you want that to look like? What's important to you? What's meaningful for you? And let's identify some goals within those areas, within those categories, because I think what's challenging, this is for all of us, there's so much information out there. You need to do this to stay fit. You need to do this. And it's overwhelming. And again, I don't think change will be made unless it's meaningful to you personally. And so starting with what's important to you, what do you value, and going from there. So if someone really does value their health and being their strongest version of themselves, for example, or maintaining their ability to sound articulate, right? Like those are areas where we might want to target, and having appropriate psychoeducation too on understanding the factors and the mechanisms behind these changes as one gets older. I know that there's a lot of psychoeducation work and a lot of values exploration in like in Gero cases, psychotherapy kind of cases. Our team has done a lot of outreach at senior centers about healthy aging, right? And that's actually a kind of a recruitment technique for us. We do a lot of info sessions about healthy aging and prevention, and then, see if people are interested in signing up to take surveys and participate in research, for example. But that's always a great way to kind of do some outreach as well. But I don't know if in terms of like initiatives or like interventions, but I think it's common, and I think it definitely could be more common, especially among those living in the community, right? How do you maintain quality of life as you get older and not just accept getting older as being inevitable and just your fate, right? And all that comes with it.
Because it seems like a lot of we also talk about when we talk about all these isms, we talk about internalized versions of those isms, and it seems like there's probably a lot of internalized ageism. I just even think of my parents, I'm old, Ben. I'm not going to change. I'm old, Ben. I'm not going to do anything new.
The whole, you can't teach an old dog new tricks.
Yeah.
Let me be. And I think another, again, and to your point, I think what also is quite difficult, we talk about we want to design prosthetic environments for individuals with the idea of slowing this functional decline, right? And then we have these tools, hearing aids, walkers, and devices to help people stay independent, yet there is so much stigma behind using these devices. And that further contributes to ageism. And so I think that's it's like a catch-22, right? I use this tool to prevent myself from further declining, yet if I use this tool, I'm considered old. And so I think that those are some major barriers that oftentimes we can work on in psychotherapy, right? Exploring some of those barriers, those internal barriers, what comes up for you, what does this mean for you? What are your own ideas about aging and ageism, and how can we address those to kind of move you forward?
Interesting you point that out too, because then not using those tools can then lead to a further decline as well. It makes me think of in healthcare settings, older adults who may even have, let's say, moderate level of dementia, or maybe even progression towards maybe more severe level. And you'll see even sometimes pushback towards wearing adult briefs, for example, if they're experiencing incontinence, right? And even though they may not communicate, or maybe it may come out spontaneously, let's say their communication sort of is at a stage where it starts to decline, their verbal communication. And you hear that, right? That pushback where, and maybe it is an internalized ageism, and, I'm not a baby. I don't want to wear that. And also them not being perhaps aware of their decline. So I can use a bathroom. I don't need to wear that. So it's that stuff. I think people have the impression that once someone experiencing cognitive decline or has a neurocognitive disorder, that those values or things that are important to them sort of just disappear, but they do come out, and maybe it's sort of intermittently every now and then, or things to do. Oftentimes resistance to using a wheelchair, or just even if those wheelchair, just be able to self-propel as needed using a walker. You see that quite often, right? And so, but you're right, like the example where you were talking about, you can't teach an old dog new tricks. I think we're all guilty of that to an extent, right? I mean, if you asked me tomorrow to join, I don't know, a curling team. I don't know the first thing about curling. I probably would say no. I wouldn't even ask any questions about
Scary. It's effort.
It's so scary, right? And I'm 35 years old, and I'd be like, no, I've never, I don't know. Or I don't know, I can't skate, for example. And you ask me to join, to, I don't know, learn how to skate, then do ice hockey. I'm saying, no, I'm too old for that.
And then that's where you're touching on like the other barriers, right? Like your own barriers to behavior change, right? And how do we address those? And that's where third wave behavioral therapies like acceptance and commitment therapy can be really useful to bring in, and motivational interviewing, those strategies to kind of help push a person towards change, as long as the change is important and meaningful for them. right?
For sure. But yeah, I do think sometimes it's naturally as human beings we'll get frustrated with our elderly parents or this person is that. But we also have to say sometimes we're often incapable of change ourselves.
Right.
And so we have to that bit of compassion for them because like I said, I'm sure there's things I could suggest to Ben, to Jacqueline, to anyone else. And you'd probably be like, no way, I'm not doing that,
Right.
right?
And again, going back to, well, who's it a problem for,
Yeah,
right?
exactly.
Someone is maybe like they're perfectly fine staying in their home and being sedentary and they don't want to change.
Quality of life for one person is not quality of life for another.
Exactly. Yeah,
Mhm.
well put.
I wanted to shift gears a bit and talk about kind of how behavior analysts can kind of get into this. And there are a lot of behavior analysts right now that are looking for options outside of the
Yeah.
autism world. And what are some what are some starting points for folks?
I think it's definitely tough because the field is still growing, right? This specialty is still growing. One of the biggest things is seeking supervision, right? Just because again, you can't just take your knowledge and skill set working in ABA and bring that to older adults.
Mm.
But again, supervision is limited as well.
Mm-hmm.
The BGSIG, the Behavioral Gerontology Special Interest Group, their goal is to kind of bring interested providers together and provide resources and a forum for those who want to learn more about behavioral gerontology and get involved in the field.
Mm.
Their website has some resources, how to get involved, questions to ask yourself.
Mm.
There's some education, training, and research opportunities that are available in North America. And I think there's even one in Iceland for those interested as well.
Wow.
So yeah, I mean, it's not an easy field to get into, I think, just because of the fact that training opportunities are limited, right? Even myself, like I knew I wanted to get more experience in behavioral analytic research, more experience in behavioral gerontology. And at the time, supervision was limited. I was hard to find someone to continue working in the field. And I wanted to further educate myself. And I ended up going to the States for my PhD to work with Dr. Claudia Drossel, who has a lot of experience working in this area and as a geropsychologist. And so it depends what route you want to take, right? There are training opportunities. You can go back to school if you'd like. And there are supervision opportunities. I know behind the scenes, the BGSIG is working on a provider list to compile a list of providers and supervisors in behavioral gerontology for those who are interested. And hopefully that'll be released or coming out soon. Um, but I would say a good place to start is the BGSIG.
Mm.
I'm actually working on that. Or I'm trying to get back to
Are
that.
you?
But
Oh,
yeah,
great.
that was one of the things we were working on. Yeah, part of the PGSIG is trying to compile that provider list. And so it'll help in multiple ways. Somebody's seeking a provider just to look for the provision of services, and then they'll be able to indicate whether or not they actually can provide supervision opportunities. One of the things I always tell my students, is working with older adults. Oftentimes, it's not just neurocognitive disorders. A lot of the time, it's psychiatric, mental health as well. A lot more individuals are interested in kind of going to that area of work that historically has not been the most popular in terms of jobs and training opportunities in ABA. But I always say just, maybe if you can't obviously pursue an opportunity to do further schooling or move or anything like that, you always want to be able to take what you currently are working with and move on to other positions where there's some sort of overlap and slowly but surely get a little bit closer to working with older adults. So for example, I started off working with children and youth with autism spectrum disorder. And then I shifted to youth and adults with autism and developmental disabilities. And from that, I was exposed to then adults with developmental disabilities, dual diagnoses, and mental health concerns. And then working with adults who have developmental disabilities, I then was able to shift a bit more into working with their parents and also working with older adults. And then in mental health settings, and I was exposed, right? See what I'm saying? So obviously, still seeking those supervision opportunities.
Mm.
It may not happen overnight, but if you know that's where you want to work one day, we know a lot of us start off working with children and youth with autism for many reasons. Obviously, that's where a lot of the opportunities are. And I would say the science, a lot of the research is there as well. So you learn a lot. It is a great place to really learn a lot of the foundational stuff in ABA. But as you're kind of, let's say you're new to the field, for example, or you've been in the field for a long time and you kind of want to build on your resume, as you move to other positions, try to get that exposure to the population, whether it's in ABA or in other settings. Because I say one of the biggest learning point, at least for myself, is communicating with an older adult and somebody who's a neurocognitive disorder and interacting with them and building the rapport is so different to doing it with a younger person or somebody that just doesn't have a cognitive or neurocognitive disorder, right? If I'm speaking to someone and they suddenly mistake me to be their daughter, right? What do? Do you go along with it? Do you correct them? Do you change the topic? Right? What do you do while still trying to build that rapport? Especially if they do that while in the context of maybe me placing a certain demand on them, in the context of providing care and I'm trying to get their buy-in. What do you do, right? Or if somebody's having responsive behaviors and maybe their wife just came to visit them and they left 5 minutes ago. And they're experiencing also maybe some paranoid delusions and they're saying, oh no, my wife is, for example, a very common thing is maybe if their wife is not there, well, she's not there, she's run off with somebody else, for example. Now they're really in a lot of distress about this, right? And their wife was just there 5 minutes ago. I haven't seen her in months. Well, what do? Do you say, well, no, she was just here, right? How offensive would that be if your reality is questioned by a person much younger than you and you as a professional are also trying to build that rapport and you correcting them may be that SD for that challenging behavior as well, right? And so I'd say just learning how, if neurocognitive disorder is something that interests you, whether it's through volunteering opportunities or working in certain settings, or just getting that exposure in general to the population, just like Jacqueline was working as a camp counselor when she was younger. I'm sure that experience helped her tremendously. Yeah, maybe she wasn't using ABA, but she worked with the population. She understood the diversity of the individuals within that population. And she was able, not to speak for you, Jacqueline, but I'm sure you're able to carry that into your work into ABA, even though it wasn't necessarily clinical work. So I would say just get that exposure because I know with the older adults, isolation is a thing. And like you said, Ben, you were saying you volunteered as a first responder and you understood, it's a town of 800 people, but you realize how a lot of other people, there's also a reason why you don't see them. So seek out those people, find them, get exposure to them. Maybe you're not going to be able to work with them clinically because obviously from an ethical standpoint, you need that supervision. But whether it's volunteering, getting that, see if it's something that works for you. And then from that point on, networking, conferences, trying to maybe get that exposure as well. A lot of conferences nowadays have that hybrid model as well. You don't maybe need to get on a plane and, go to a conference, maybe, but seeking out those opportunities. And then of course, like the BGSIG and organizations like that, I think would be really quite helpful.
And I know the BGSIG, they also have, like anyone can go on the website and interact with all the resources, but they also have members only benefits as well, where there's more CEU opportunities, training videos. And so it's just a great resource to get involved. You can purchase your membership through ABAI's website as well. And the membership kind of renews the same time that your ABAI membership renews as well. And so I think that's a really great place to get started. Join the online forum on Facebook and group discussions where you can share questions, how to get involved, ask if there's supervision available. I'd say that's a good place to start and then just reach out and network. And like Nehal said, just work your way up, right? Sometimes you may get indirect exposure to working with that or older adult populations. Let's say you do work in a psychiatric setting in a lot of mental health, you're bound to work with some gero patients from time to time and just kind of go from there.
That's awesome. This question may just probably will trigger just having another interview with somebody, maybe one of you. But I also think there's probably folks listening that are wondering about this, because I know I do often, is about sort of the intersection between sort of the intellectual disabilities, autism world and the gerontology world. A lot of our folks are aging. I just listened to a podcast on sort of adults with autism, and someone was just pointing out the obvious that every kid with autism 15 years later becomes an adult with autism. And so we're going to start seeing, if we aren't already, a lot more. And, these individuals used to just end up in institutions, and that's why we weren't sort of seeing them in community. But now we're going to start seeing them in, these facilities and in these contexts. And it's certainly for some of our folks with maybe higher support needs, things are going to present a lot differently as well. Are there folks doing that kind of work around sort of the intellectual disability aging kind of crossover, and are there
I
Yeah, maybe.
know Dr. Zoe Lukacs, she actually is the I don't know, the president of the
Sure.
BGSIG. I don't know if
Okay.
I don't know if that's the right
Right.
term. I should know this because I was on the BGSIG.
Right.
But she does a lot of work in dual diagnosis and that crossover
Hmm.
between
Okay.
neurodevelopmental and neurocognitive disorder. And she actually, her business, she does CEU opportunities. So she does a lot of training videos in behavioral gerontology. And she actually just did release one on this dual diagnosis piece
Oh,
as
right
well.
on.
So it's a great opportunity to kind of learn more and kind of get
Trying to think
some
of the
more
name, Jacqueline.
education. Sorry?
I'm trying to think of the name
Of
of
what? Sorry.
Zoe's.
I can pull it up because I
Yeah.
did purchase the CEU to do because that's something I definitely would love to
Oh, is
get
it Enrich?
enrich behavioral.
Enrich.
Hmm.
There you go. Yeah.
Awesome.
Yeah, and she's done other work previously, and actually myself working in the field, I've watched a lot of her content, purchased her CEUs, because again, in our life, it's when the time comes to obviously you want to work on your CEUs gradually, you want to make sure it's something that's of interest to you, right? And so I was having a
Hmm.
hard time finding it when I found it before I joined actually the BG SIG. I even learned a lot, and the abundance of research that she shares through her work is really quite helpful to someone like myself who's been in the field for quite some time. So yeah, I do recommend that as well, because even research wise, it's not just like a Google search of ABA older adults. The research on behavioral gerontology is published across many journals, some of which you may not have heard of, and so it was quite helpful for me as well to kind of build up on my resources.
Hmm.
Definitely.
Hmm. Hmm. Yeah,
And
and I
again,
think.
I think
Oh, go ahead.
sorry, Ben, I was just going to add, going back to what we had talked about, I think when it comes to working with adults with neurodevelopmental disabilities, those same rule outs we've been talking about really do apply before you land on dementia, if dementia is at play. And I think just always keeping that checklist in mind is a really great place to start, even if you're not really too experienced in the
Hmm.
crossover. I think just, asking yourself, is it dementia or is it
Mhm.
all of it? Could it be one of these many other things that I have
Hmm.
to consider before I continue?
And because another area I think about too a lot is just working in adult group homes. And, a lot of these individuals are going to age in those group homes. They're not going to move necessarily to a long-term care facility or something, something different, possibly because, this is, well, just because there aren't resources for that, and they're already in a staffed resource. So they might want to kind of just keep them there. And so I also just think about sort of how as we're trained, a lot of our role is training staff in group homes and, to sort of work with these individuals. And I think folks are going to have to more and more start thinking about adding that piece to their training.
Definitely. Yeah. And so I think another area for behavior analysts to hopefully make a name for themselves in and be
Mm.
part of the team there. I think that's a great opportunity. Hard, it's hard to get in. I don't quite know. You have to, it's just about networking and finding the
Hmm.
opportunities, right? It's not like
Yeah.
their positions aren't made for you at this point.
No. I think Dr. Lukac might have worked with the guest I had on way back. It was episode 17, Dr. Rebecca Sharp.
Yep, I think they published one of the articles together
Yeah,
on the
yeah,
crossover dual diagnosis.
yeah. And she told me early on that you're not just gonna find these jobs like this. I mean, this was 4 or 5 years ago, and she was saying, and she was in the UK, and she was basically saying, you really just have to go get a job at a nursing home and potentially work your way up the ladder and sort of show folks, kind of what you can do depending on where you are. If you're not lucky enough to have sort of these support teams like maybe Ontario has, that sort of thing. So sometimes it's just sort of climbing the ladder and introducing your skills to folks and pairing yourself with reinforcement and kind of getting in that way.
I do
Yeah.
know that for the BGC as well, one thing that we're advertising is a peer consultation group. So they kind of
Cool.
they're virtual. They sort of happen as needed. You'd have to be a member, but
Neat.
I mean, like you said, right, you're going to come across these individuals that are really complex cases. And sometimes there isn't someone out there that's perfectly experienced at that crossover. But at least with these peer consultation groups, you can just sort of bounce ideas off each other, obviously, and
Mm.
just maybe they can direct you in the way of research or other areas or resources that might be quite helpful to you. So that's something as well that we often we advertise, because it is a small area of work. And I
Yeah.
mentioned earlier, being on interdisciplinary teams sometimes is really great, but sometimes it's a little bit isolating if you're the only person. I miss the day sometimes I could just turn, look over my shoulder and ask my colleague in an autism program, hey, what do you think about this? Or do you have resources or materials for that? Right. All of a sudden, it's just you that has the background and training and experience, which it's great. It's rewarding, but at the same time, you kind of miss that, you know, those days where you could work on really large teams where people have a similar mindset and training. So I think having that peer consultation opportunity would be really great for some people working in residential settings for adults with intellectual and developmental disabilities, because sometimes it's hard and sometimes even impossible to assess for cognitive changes in individuals that maybe have really a higher level of need and support with their daily living skills if they're non-vocal or nonverbal and they aren't able to communicate certain things.
Yeah, great point. Like at what, those
How
same
do you
cognitive
know?
tests that you would administer to diagnose dementia
Yeah,
aren't applicable
you
to
can't.
someone who may be nonverbal.
Exactly. You can't administer the
Mm-hmm.
MOCA or the MMSC to somebody who maybe has more, severe autism and isn't able to
Mm-hmm.
communicate verbally.
Right.
And we know that with individuals that are experiencing these challenges as well, even just assessing for medical changes, right? I've had many clients back in the day unfortunately, by the time they go to the ER, they go to the hospital to get help, right? It's a lot further than somebody who is neurotypical because they can't sort of express that they're experiencing these challenges earlier on. And so cognitive challenges on top of that, yeah, you might see sort of, oh, well, they have autism or they have this or they have that. And you mentioned earlier, Ben, individuals who have Down syndrome.
Mm-hmm.
Jacqueline, maybe you know this task more than I do, but I've heard it's somewhere 40 to 50%, I believe, by the time they reach a certain age, that they're likely to develop a dementia. I think also because of things like vascular dementia, especially with Down syndrome, and a lot of the heart disease and the challenges that they face. And so if somebody's not able to express that, I'm sure maybe with Down syndrome that people are more trained to screen for it rather than maybe autism or other developmental disabilities. And so it's true. First of all, how do we even detect it in individuals in those settings? And then are group homes equipped to deal with these changes? I remember, kind of on the flip side, then you also see individuals with mental disabilities that don't have cognitive needs that end up in long-term care homes because there's nowhere else for
Yes.
them to go.
Right.
I met
Right.
a
Yes.
young man
I've
with,
seen
I think
that.
it was spina bifida, who was I think he was in his 30s, who was in a long-term care setting, right? And it was just a reflection of those gaps in the system. And so I think there's a lot to discuss, but you're right. Our population is aging rapidly. People are having less children. You see more of that sandwich generation, people in their 30s and 40s that have very young children, but much elderly parents and caregiver
Mm.
burnout. And so people are being kind of placed wherever they can be placed, because sometimes it becomes a crisis situation at home. And how do we make sure that if there is that crossover, that they're properly cared for?
Yeah. Lots of different directions to go here. We'll definitely link folks to the special interest group website and the Facebook page, and hopefully they can learn more. Nehal, Jacqueline, this was amazing. So good learning about gerontology from you folks, and so cool to hear about the work you're doing, and stoked to see where things go.
Thanks so
Thanks for
much
coming
for
on.
having me on. It's been fun. Thank you.
Yeah, awesome.
Thanks so
Thanks,
much.
Nehal. Good to see you again.
Likewise.
The third secret word is cognitive. Check out my in-depth interview with Nehal in episode 228, The Nubian Egyptian Behavior Analyst with Nehal Siam. And go back into the vault to episode 17 to learn more about behavior gerontology with Dr. Rebecca Sharp. You can find us on Instagram and TikTok and subscribe to our YouTube page at Behavior Speak. And if you enjoyed this episode, please leave us a review on Apple Podcasts or Spotify.